Welcome to the deep dive. Today we're looking at something our eyes do that, well, we usually take for granted, staying still.
Right.
But sometimes they don't.
Right.
And those involuntary movements, nystagmus in adults, they can actually be a really important signal about what's going on health-wise.
Exactly. It might just look like a slight shaking or drifting of the eyes.
Yeah.
But new onset nystagmus in adults, that's often a critical clue. It can point doctors towards underlying issues, maybe in the brain, maybe the inner ear.
Okay, so what exactly is it we're seeing when we talk about nystagmus? Can you paint a picture for us?
Sure. Essentially, it's an uncontrolled sort of rhythmic back and forth or maybe up and down movement, one eye or sometimes both.
Right.
The most common type, that's jerk nystagmus. Imagine your eyes slowly drifting off to one side and then zip a quick little jump back to the center.
Ah.
And that quick jump, that's what defines the direction we say the nystagmus is going.
So a slow wander and then a snapback.
Got it.
Is there like another kind?
Yes. The other main one is called pendular nystagmus.
Pendular.
Yeah, think of a pendulum, swinging smoothly back and forth.
Okay.
In this case, the eye movements are more like a gentle, even oscillation. You don't really have that distinct fast and slow phase like you see in jerk nystagmus.
I see.
But what's really key, the thing to remember for the nystagmus we're concerned about, the kind that signals a potential problem, is that the movement always starts with that slow drift.
Always the slow drift first.
Right. That helps us tell it apart from, other quick eye movements that aren't quite the same thing.
You mentioned that when this starts in adulthood, it's a red flag.
Mm-hmm.
Why is that so significant?
Well, because in adults, the systems controlling our eye movements are usually very stable, really well tuned. So if nystagmus suddenly appears, it strongly suggests that something has, interfered with that stability, thrown a wrench in the works.
Okay.
That's why it really needs a thorough medical check. We need to see if there's a neurological or maybe an inner ear condition causing it.
Makes sense.
And it's not just that the eyes are moving, it's the specific pattern, the type of oscillation, the direction, how it changes when you look different ways or try to focus. These are all vital pieces of the puzzle for diagnosis.
So the how is just as important as the what. Okay, now let's get into the why. What's actually going wrong in the body that leads to these eye movements?
Right. So nystagmus happens when there's a disruption in the normal teamwork. The systems that keep our gaze steady, they're not quite in sync.
Like musicians playing off key.
Exactly like that. We have a few key systems involved here. There's the vestibulo-ocular reflex, the VOR.
Yep.
That's like your built-in stabilizer. Keeps vision clear when your head moves. Then there's smooth pursuit, lets you track a moving target smoothly.
Following a bird flyby, for instance.
Precisely. We also have the optokinetic reflex, which helps when your whole visual field is moving, like watching scenery from a train. Vergence helps the eyes work together, focusing near or far. And finally, there's something called the neural integrator. Think of it as the brain's command center telling your eyes, okay, look here, now stay here.
So if one of these systems hiccups.
Exactly. If there's a problem affecting those slower systems, VOR, pursuit, optokinetic, vergence, or if that gaze-holding neural integrator isn't working right, it can lead to that slow drift we talked about, followed by the quick correction, that's the jerk nystagmus.
Can you give an example?
Sure. Imagine a sudden issue with the balance organ in just one inner ear.
Okay.
That creates a mismatch in the signals going to your brain. So your eyes might slowly drift towards the side with the problem, the weaker side, and then quickly jump back to the center to try and compensate.
So an inner ear imbalance throwing off the eyes. That makes sense. What about the pendular nystagmus, the smooth swinging? Where does that come from?
Good question. Pendular nystagmus is thought to arise from an instability specifically in that gaze-holding mechanism.
The neural integrator thing?
Exactly. It's like the system that's supposed to keep your eyes still has developed a little wobble,
Yeah.
causing them to oscillate rhythmically back and forth.
Now, the cerebellum,
Yeah.
I know that's crucial for coordination.
Yeah.
Does it play a role here?
Oh, absolutely. The cerebellum is like the master coordinator for all our eye movements. It fine-tunes everything, stabilizes these systems.
Okay.
And specific parts of the cerebellum are really important. For instance, the floccular and parafloccular regions, they help adjust the VOR, especially when we make quick head movements.
Right.
Other areas, the nodulus and uvula, they deal more with the VOR during slower head movements and also process information about, our sense of balance and gravity from the inner ear.
So problems in those specific cerebellar areas could lead to specific kinds of eye movements.
Precisely. If the floccular region isn't working right, we might see something called downbeat nystagmus, eyes drift up, fast beat down,
Yeah.
or gaze-evoke drift, where the eyes just can't hold steady when looking off to the side. And issues with the nodulus and uvula, they can mess with the brain's ability to sort of store information about head movement. That can potentially lead to periodic alternating nystagmus.
Periodic alternating.
Yeah, where the direction of the nystagmus actually flips every couple of minutes. Pretty unusual.
Wow. It's amazing how targeted the brain's control is. What about the brainstem? Does that factor in?
Yes, definitely. The brainstem contains really important centers that help control where we're looking. Names like the nucleus prepositus hypoglossi and the interstitial nucleus of Cajal.
Okay, technical names.
Right, but they're key parts of that neural integrator we discussed, the gaze-holding system.
So if they're damaged?
If these areas are damaged, they can become, well, leaky, meaning they can't hold the eye position steady. This often results in gaze-evoke nystagmus, the kind that appears when you look away from the center.
Okay, so let me try and sum this up simply. Nystagmus can come from basically inner ear problems, issues with the brain's reset mechanism for eye movements, or a failure in the brain to keep our eyes locked on target.
That's a good way to put it.
And the cerebellum is kind of this crucial fine-tuner overseeing it all.
Exactly right. It boils down to an imbalance in signals from our balance system, maybe a glitch in how the brain recalibrates eye position, or a problem with the brain's ability to just maintain steady gaze. And yeah, the cerebellum plays that vital modulatory role, keeping everything working smoothly.
Okay, we understand the why a bit better now. Now for the what are the actual conditions that can cause nystagmus in adults? I imagine it's a pretty broad list.
It is, yeah. It's quite varied. We generally try to categorize the causes based on their origin, where the problem is located.
How do you categorize them?
Usually into three main groups. Issues in the peripheral vestibular system, that's basically the inner ear and its nerve.
Okay.
Problems within the central nervous system, the brain and spinal cord.
Right.
And then a sort of broader category for other potential causes, things that don't fit neatly into the first two.
Got it. Let's start with the peripheral vestibular causes then, the inner ear issues.
Yeah.
What are some common examples there?
Sure. These often involve problems directly with the inner ear structures or the nerve connecting it to the brain. Common examples would be things like a vestibular neuritis or labyrinthitis, basically inflammation.
Inflammation, okay.
Then there's Meniere's disease. You might have heard of that, episodes of vertigo, hearing loss, ringing in the ears.
Yes.
And a really common one, benign paroxysmal positional vertigo, or BPPV. That's often triggered by specific head movement. In fact, BPPV is the most frequent cause of peripheral vertigo overall.
Wow, yeah. Anything else on the peripheral side?
Yeah, a few others. You can have benign tumors on the balanced nerve vestibular schwannomas, sometimes called acoustic neuroma.
That's right.
Or things like abnormal openings or connections in the inner ear,
Yeah.
a paralimbal fistula, or maybe semicircular canal dehiscence.
Mm-hmm.
Trauma to the inner ear can do it too. And also ototoxicity.
Ototoxicity.
Yeah, damage to the inner ear from certain medications. Some strong antibiotics, like aminoglycosides, are known culprits.
Okay. And what kind of nystagmus do these inner ear problems typically produce? What does it look like?
Typically, they cause a jerk nystagmus. It's usually either horizontal, side to side, or a combination of horizontal and torsional, meaning a bit of twisting.
Okay.
And the fast phase, that quick jerk back, it usually beats away from the side that's affected. And a really key characteristic is that this type of nystagmus tends to get better or even disappear when the person tries to visually focus on something.
Focusing helps. Got it.
Yeah.
Now let's move on to the central nervous system causes. This sounds like it could cover a lot more ground.
It does, yeah. Central causes involve conditions affecting the brainstem, the cerebellum, or sometimes pathways higher up in the brain.
So what are some key examples here?
Well, strokes are a big one, especially in the back part of the brain, the posterior fossa. Think strokes affecting arteries like Pisca or AICA.
Strokes, okay. What else?
Multiple sclerosis, MS plaques developing in the brainstem or cerebellum can definitely cause it. Space-occupying lesions.
Meaning tumors?
Yeah, tumors in the brainstem or cerebellum or meningiomas growing near the brainstem, pressing on things. Also, certain degenerative conditions that affect the cerebellum.
Like what?
Things like alcoholic cerebellar degeneration from chronic alcohol abuse, or various types of spinocerebellar ataxias, which are inherited disorders.
Okay.
Also, Wernicke's encephalopathy that's caused by a severe thiamine, vitamin B1 deficiency. And certain toxic or metabolic problems, maybe side effects from medications like phenytoin or lithium.
That's already a significant list. Are there other central causes we should be aware of?
Yes, definitely. Things like vestibular migraine can cause nystagmus. Certain immune reactions targeting the nervous system, called paraneoplastic syndromes.
Mm.
Other demyelinating diseases besides MS, like neuromyelitis optica, and a structural issue called Chiari malformation, which sometimes causes a specific downward beating nystagmus.
Yari. Okay.
And of course, inflammation of the brainstem itself, encephalitis, or significant trauma to the brainstem can damage those balance and eye movement centers.
So it seems really important to distinguish.
Absolutely. It's really crucial to remember when nystagmus develops in adulthood, especially if it comes along with other neurological symptoms, weakness, numbness, coordination problems, slurred speech that strongly suggests a central nervous system origin.
That makes total sense. It wouldn't just be an isolated eye or ear issue then. What about those other or more general causes you mentioned earlier? What falls into that bucket?
Right. This is sort of a catch-all category. It includes less common causes like lesions directly affecting the eye movement muscles themselves, though that's pretty rare in adults,
Okay.
or diseases of the visual pathways. Usually, though, those cause nystagmus that's present from birth, congenital nystagmus, rather than developing later in life.
So less likely in adults. What else?
Nutritional deficiencies are important, particularly that thiamine deficiency leading to Wernicke's encephalopathy.
Right, you mentioned that under central causes too.
Yes, it impacts the central nervous system directly. Certain systemic diseases, like MSS again, can fit here too. And the effects of chronic substance use, alcohol, sedatives, certain anticonvulsant medications can sometimes trigger nystagmus.
Interesting.
And here's something interesting. Sudden hearing loss in just one ear can sometimes lead to a vestibular-type nystagmus, while problems affecting hearing in both ears can sometimes cause oscillopsia, that feeling of the world moving,
Oscillopsia.
along with either gaze-evoked nystagmus or even spontaneous nystagmus, which in some cases might be that pendular type.
You also touched on some rare syndromes linked to very specific types of nystagmus. Can you give us a quick rundown of those? They sounded quite distinctive.
Certainly. They are rare, but recognizing them can be very helpful diagnostically. Seesaw nystagmus, for instance.
Seesaw.
Yeah, the eyes literally move like a seesaw. One goes up and twists in while the other goes down and twists out, then they alternate. It's often associated with problems around the pituitary gland area or in the midbrain brainstem. Then there's periodic alternating nystagmus, PAN, which we mentioned before. The direction of the jerk nystagmus reverses, usually every 90 to 120 seconds or so, often linked to issues in the cerebellum's nardulis and uvula, or it can be congenital.
Okay. Any others?
We also see other unusual eye movements, sometimes grouped nearby, ocular bobbing, quick downward eye movements, slow return up, often seen in comatose patients with severe brainstem injury,
Bobbing, okay.
and ocular flutter or opsoclonus. These are really rapid, involuntary, back-to-back saccadic eye movements, like the eyes are just jumping uncontrollably all over the place. Also often points to brainstem or cerebellar dysfunction.
Flutter and opsoclonus.
And lastly, maybe the Hyman-Bielszowski phenomenon. It's a very rare type of pendular nystagmus that occurs in just one eye, and typically it's an eye that has poor vision for some other reason.
So while rare, seeing one of these very specific patterns can really help narrow down where the problem might be.
Exactly. They can be strong clues.
It sounds like figuring out the exact cause requires a really detailed investigation. So what do doctors actually look for when they examine someone presenting with nystagmus?
Right. A thorough neuro-ophthalmologic exam is absolutely key. It starts, as always, with a detailed history.
What kind of questions?
We need to know when it started. Was it sudden or gradual? What seems to trigger it or make it worse? Positional changes, head movements, trying to focus. Any associated symptoms are crucial.
Like dizziness?
Exactly. What kind of dizziness or vertigo, any hearing changes, loss, ringing, double vision, problems with balance, walking, coordination, and importantly, do they feel like the world is shaking or bouncing? That's oscillopsia.
Oscillopsia,
And
yeah.
sometimes people adopt an unusual head posture to try and minimize the nystagmus and see better, so we ask about that too.
Okay, so history first.
Mm-hmm.
Then what does the physical examination itself involve? How do you actually look at the eyes?
The exam is done very systematically, step by step. First, the doctor will simply observe the person's eyes while they're looking straight ahead in primary gaze.
Just watching.
Yes. Then we often use special Frenzel glasses or infrared video goggles. These have lenses that prevent the person from focusing visually on anything specific.
Why do that?
Because, as we said, peripheral nystagmus often gets suppressed by fixation. Removing fixation can make the nystagmus much more obvious, easier to see and characterize.
Ah, okay. Makes sense.
Then we'll check gaze in different directions, have them look far right, far left, up, down. We're looking to see if the nystagmus changes direction or if it only appears when looking in those extreme positions. That's gaze-evoked nystagmus.
You mentioned earlier that nystagmus from inner ear problems often improves with focusing. How do doctors test that specifically?
We directly compare. We observe the nystagmus without fixation using the goggles, then we have them remove the goggles and focus on a target, like the examiner's finger or a distant object.
And you see if it changes.
Exactly. If the nystagmus clearly becomes less intense or maybe even stops completely when they focus, that's a strong clue. It might be peripheral coming from the inner ear.
And if it doesn't?
If it persists, or sometimes even gets worse with attempted fixation, especially if it's a vertical nystagmus or one that changes direction with gaze, that points much more strongly towards a central brain-related cause.
Okay. What about those specific tests we sometimes hear about, like the head impulse test?
Yes, the head impulse test or the head thrust test, sometimes called the Hamagai test, it's really important. It checks the function of the vestibulo-ocular reflex, how well the inner ear's balance system is working, especially at high speeds.
How's it done?
The examiner holds the person's head and asks them to keep their eyes fixed on the examiner's nose. Then the examiner gives the head a quick, small, unexpected turn to one side.
What are you looking for?
We're watching the eyes. Normally, the eyes should stay locked on the target. If the balance system on the side the head was turned towards is weak, a peripheral problem, the eyes will get dragged along with the head briefly.
Off target.
Right, off target. And then the person has to make a quick corrective eye movement, a catch-up saccade, to get their eyes back on the nose. Seeing that catch-up saccade indicates a problem with the peripheral VOR on that side.
Interesting. But you said earlier.
Ah, yes. The interesting twist is, if someone comes in with acute, sudden vertigo and nystagmus, but they have a completely normal head impulse test, meaning their eyes stay perfectly on target during the thrust, that can actually be a red flag.
A normal result is bad.
In that specific context, yes. A normal head impulse test in someone with acute vertigo syndrome suggests the problem is not likely in the inner ear, making a central cause, like a stroke affecting the brainstem or cerebellum, much more likely.
Wow. Okay. So a normal result can sometimes be more concerning in that situation.
Right.
What about the skew test? What's that checking?
The skew test, often done as the cover-uncover test, checks for vertical misalignment of the eyes. We call this a skew deviation.
How does it work?
The examiner has the patient look at their nose, then covers one eye for a second or two, and then quickly uncovers it while watching that eye very closely.
Looking for movement.
Exactly. Looking for any vertical movement, does the eye have to move up or down to realign with the other eye once it's uncovered? Finding a skew deviation, a vertical misalignment, is another one of those signs that often points towards a problem in the central nervous system, particularly the brainstem.
Okay. And for positional vertigo, like BPPV, I know there are specific maneuvers involved.
Yes, absolutely. If BPPV is suspected based on the history vertigo triggered by lying down, rolling over, looking up, then specific positional tests are done. The Dix-Hallpike maneuver is the main one for the most common type of BPPV,
Right.
and sometimes the supine roll test for other variants. These specific head and body movements are designed to move the little crystals in the inner ear and trigger that characteristic brief burst of nystagmus if BPPV is present.
And is that different from positional nystagmus caused by central problems?
Yes, typically. The nystagmus in BPPV usually has a short delay before it starts. It's often torsional and vertical, lasts less than a minute, and fatigues with repetition. Positional nystagmus from a central cause might also be triggered by position changes, but it often starts immediately, can last longer, might be purely vertical or horizontal, and typically doesn't fatigue in the same way.
Okay, that distinction is important. And finally, what does a general oculomotor exam add? What else are you looking at?
This part looks broadly at how well the eyes move together and individually. We check smooth pursuit again. Can they follow a target smoothly? Saccades, can they jump accurately between targets without overshooting or undershooting? Convergence, can the eyes turn inward properly to focus up close?
Checking all the basic movements.
Right. We also recheck gaze holding carefully in all directions. We look for any subtle misalignments, any limitations in movement, any signs of specific problems like internuclear ophthalmoplegia, INO, or signs of cerebellar issues like dysmetria where the eye movements are inaccurate. It's about getting the complete picture of eye movement control.
So putting it all together, there's a lot that doctors look for to try and distinguish between these inner ear peripheral causes and the brain-related central causes of nystagmus. Can you give us a quick summary, like a checklist of the key distinguishing features?
Sure, it's helpful to compare them side by side, though remember these are general patterns, not absolute rules,
Okay.
direction-wise. Peripheral nystagmus is usually unidirectional, meaning the fast phase beats the same way regardless of gaze direction, often horizontal or horizontal torsional. Central nystagmus, on the other hand, often changes direction with gaze beats right and right gaze, left and left gaze, and it's more likely to be purely vertical or purely torsional.
Direction changing is central. Got it. What else?
Fixation suppression. Peripheral nystagmus usually gets much better or stops when you focus visually. Central nystagmus often persists or might even get worse despite fixation.
Okay.
Gaze-evoked nystagmus, the type that appears only when looking away from center, is relatively rare in peripheral disorders, but quite common with central problems, especially cerebellar or brainstem issues.
Right.
The head impulse test. Typically abnormal, showing that catch-up saccade, in peripheral vestibular loss, but often normal in central causes presenting with acute vertigo.
The normal is bad sign.
In that specific context, yes. Auditory symptoms. Things like hearing loss or tinnitus often accompany peripheral vestibular disorders, but are usually absent with central causes, unless the lesion happens to affect auditory pathways too.
Makes sense.
Other neurological signs, generally absent in purely peripheral vestibular problems, but often present with central causes, think ataxia, dysarthria, weakness, sensory changes.
Right, the company it keeps.
Exactly. And skew deviation. That vertical misalignment we talked about, usually absent in peripheral cases, but may be present with central pathway involvement.
So if someone has, say, purely up and down nystagmus, or if it clearly changes direction when they look left versus right, that should really make you think central.
That's a very, very important takeaway. Any purely vertical nystagmus, upbeat or downbeat, or purely torsional nystagmus, or nystagmus that is clearly direction changing on lateral gaze, is highly suggestive of a central nervous system problem until proven otherwise.
Okay.
Similarly, if the nystagmus does not get better when the person tries hard to focus, or if there are any other associated neurological symptoms, the suspicion for a central cause goes way up.
That's really clear. Once a doctor has done the physical exam and has these clues, how is nystagmus actually definitively diagnosed? Are there specific tests they use to confirm what's going on?
Yes, absolutely. While the clinical exam gives us a huge amount of information, testing often helps confirm the diagnosis or clarify ambiguous cases.
Like what kind of tests?
Well, often specialists will use high-resolution video recordings of eye movements. This is called video oculography, or VOG, sometimes using those infrared Frenzel goggles we talked about.
What does that add?
It allows for a very detailed, objective, and quantifiable measurement of the nystagmus. We can measure the speed of the slow phase, the frequency, the amplitude, the exact 3D direction of eye rotation. This can provide much more precise clues about the underlying cause than just observation alone.
More data.
Yeah.
Right. And what about that HINTS protocol you mentioned? You said it's important for acute vertigo. How does that fit into diagnosis?
Right. The HINTS protocol, which stands for Head Impulse, Nystagmus Type, and Test of Skew, is a really crucial bedside diagnostic tool. It's specifically for patients presenting with what we call acute vestibular syndrome, sudden onset of severe continuous vertigo, nausea, vomiting, gait instability, and nystagmus.
Okay.
It combines those three key parts of the clinical exam we discussed. The critical finding is this. In a patient with acute vestibular syndrome, if the head impulse test is normal,
Normal head impulse.
plus they have nystagmus that changes direction with gaze or is purely vertical decoded, or they have a skew deviation on cover testing, that combination is highly predictive of a central cause, most often a stroke.
So HINTS helps flag potential strokes quickly.
Extremely effectively. In fact, studies, like the one by Kata and colleagues back in 2009, showed that the HINTS exam performed by trained examiners can actually be more sensitive for detecting stroke in the first 24-48 hours than even an early MRI scan.
That's incredible that a bedside exam can be so powerful. What role does brain imaging play then? When do you do an MRI?
Neuroimaging is absolutely essential when we suspect a central cause based on the HINTS exam or other clinical signs. MRI of the brain, with specific attention to the brainstem and cerebellum using thin slices and sequences like DWI, diffusion-weighted imaging, to look for acute stroke or flare for demyelination, that's really the gold standard.
MRI is key for central causes.
Yes. Contrast enhancement might be used if we suspect a tumor or inflammation. If MRI isn't immediately available or is contraindicated, a CT scan, maybe with CT angiography to look at blood vessels, can be an alternative. But it's important to know that CT can sometimes miss small or early strokes in the posterior fossa.
Okay. Are there other types of tests that can help figure out if the problem is definitely peripheral in the inner ear or confirm central dysfunction?
Yes, there's a whole battery of vestibular function tests that can be very helpful, especially in more complex or ambiguous cases.
Like what?
Caloric testing is an older but still useful test. It involves putting warm or cool water or air into the ear canal to stimulate the horizontal semicircular canal and measuring the nystagmus response. It tells us if one side is weaker than the other.
Okay.
Rotational chair testing looks at the VOR over a wider range of frequencies, especially lower frequencies, by rotating the person in a specialized chair. The video head impulse test, or VHIT, is a newer technique that uses high-speed cameras to precisely measure the VOR gain for quick head movements for all 6 semicircular canals.
VHIT sounds quite advanced.
It is very informative. Then there are VMPs, vestibular evoked myogenic potentials. These tests assess the function of the otolith organs, the parts of the inner ear that sense gravity and linear acceleration rather than rotation.
Testing different parts of the balance system.
Exactly. And alongside these, we'll almost always do hearing tests, audiometry, to check for any associated hearing loss, which can provide more clues. In very rare situations, if there's a suspicion of seizures causing unusual eye movements, an EEG might be considered, but that's uncommon for typical nystagmus.
It sounds like there's a real emphasis on using a combination of careful clinical examination and then targeted, often high-tech testing.
Absolutely. It's an evidence-based approach. We rely heavily on validated bedside protocols like hints in the acute setting and specific diagnostic maneuvers like Dix-Hallpike for a suspected BPPV.
Right.
There are efforts by groups like the Barony Society to standardize the nomenclature, the way we describe and classify different types of nystagmus, which is really important for clear communication between doctors and for research.
Standardization helps everyone.
Definitely. And as we mentioned, quantitative VOG analysis is becoming more widely used in specialized centers to get those precise measurements. But ultimately, when the diagnosis remains unclear after the initial workup, referral to specialist neurotologists or neuro-ophthalmologists who have expertise in these complex disorders is a crucial step.
So to bring this all together then, what's the main message we should really take away about nystagmus in adults?
I think the biggest takeaway is that new onset nystagmus in an adult isn't just a curiosity. It's a significant clinical sign that really warrants careful medical evaluation.
Ignore it.
Exactly. And being able to distinguish between nystagmus that originates in the peripheral vestibular system, the inner ear, versus the central nervous system, the brain, is absolutely crucial. That distinction relies heavily on a thorough clinical examination and really understanding the specific characteristics of the eye movements observed.
And it's not just about identifying the eye movement itself, is it? It's about understanding what that movement might be telling us about the person's underlying health.
Precisely. By carefully integrating those key bedside assessments, like the HINTS protocol, with the advanced technologies we now have, like detailed eye movement recording and targeted neuroimaging, we have really powerful tools to diagnose the underlying cause of the nystagmus.
And getting that diagnosis right is key.
It's essential, because accurate diagnosis is the first step towards ensuring timely and appropriate treatment for potentially serious conditions, whether it's a stroke, a demyelinating disease like MS, an inner ear disorder like BPPV or Meniere's, or something else entirely.
It really is fascinating, isn't it? How these seemingly subtle, involuntary eye movements can act as such a revealing window into the incredibly complex workings and sometimes the vulnerabilities of our nervous system.
It truly is.
It definitely makes you appreciate the intricate balance and coordination required for something we rely on every moment, just maintaining stable vision. Thanks so much for taking this deep dive with us today and shedding light on such an important topic.
My pleasure. It's a fascinating area.